Hi, my name is Allison Betof. It's a pleasure to be back with you for the 2026 OncoAlert Colloquium with 2025 highlights in melanoma. So let's dive right in. To start, we're going to start off talking about the adjuvant and neoadjuvant settings and talk about advancements in those therapies in 2025, followed by metastatic melanoma, ocular melanoma, summarize what was practice changing in 2025 and what to get excited about for 2026. Let's dive right in. So we're going to start by talking about CheckMate 76K, which is the adjuvant study of nivolumab for resected stage 2B and 2C melanoma. This was a global randomized double-blind phase 3 study that led to the approval of nivolumab for patients with this indication. And these patients were randomized 2-to-1 to either nivolumab 480 milligram flat dose every 4 weeks for 12 months or placebo. The primary endpoint was recurrence-free survival as assessed by the investigator, and key secondary endpoints, of course, safety, distant metastasis-free survival, progression-free survival, and overall survival. So we recently saw the 4-year update presented by Dr. John Kirkwood at ESMO 2025. If you look on the left, you're looking at recurrence-free survival. The right is distant metastasis-free survival. And you can see at the 4-year or 48-month mark, recurrence-free survival is 66% in the patients who were treated with nivolumab versus 55% in the patients treated with placebo. And that difference is statistically significant. And the difference in distant metastasis-free survival, which we know is really the critical endpoint, as that is a huge determinant of prognosis for these patients, is 74% at 4 years in patients treated with nivolumab versus 69% in patients treated with placebo. And again, statistically significant difference. We also saw updates at ESMO this year and ASCO from the NADINA trial, which looks at neoadjuvant nivolumab plus ipilimumab. This is a phase 3 randomized trial of that neoadjuvant regimen versus adjuvant nivolumab in patients with macroscopic resectable stage 3 melanoma. These patients had at least one lymph node proven metastasis and 3 or fewer in-transit metastases. There were 423 patients randomized 1-to-1 to either the neoadjuvant arm or the adjuvant arm. In the neoadjuvant arm, patients received ipilimumab 80 milligrams IV, which is essentially 1 milligram per kilogram, plus nivolumab 240 Q3 weeks for 2 cycles, versus going straight to surgery. The patients who got neoadjuvant Ipi plus Nivo then had surgery with a therapeutic lymph node dissection. And if patients had a major pathologic response, meaning 10% or less viable melanoma, they got no further treatment. If patients did not have that major pathologic response or greater than 10% residual viable melanoma, they received adjuvant therapy per their BRAF status. So if the patients were BRAF wild type, then they went on to continue adjuvant nivolumab. And if the patients were BRAF mutated, then they went on to get adjuvant dabrafenib and trametinib. Adjuvant radiation was allowed in these patients. The patients in the surgery first arm received that therapeutic lymph node dissection, followed by 1 year of adjuvant nivolumab, 480 milligrams Q4 weeks times 12 cycles, or the standard dosing of adjuvant nivolumab. The primary endpoint here was event-free survival with key secondary endpoints, overall survival, pathologic response rate, recurrence-free survival, and distant metastasis-free survival. If we look at the event-free survival, you can see the update here at 2 years, which was provided by Dr. Minka Lucas at ESMO. And that event-free survival was 77.3% in the neoadjuvant arm versus only 55.7% in the adjuvant PD-1 arm. And distant metastasis-free survival, again, crucial endpoint in these studies, 82.8% in the neoadjuvant Nivo plus Ipi arm versus 63.9% in the adjuvant Nivo arm. You can see additionally here, broken down into different cohorts, different prognostic markers, baseline interferon gamma signature, baseline PD-L1 status, and baseline event-free survival. And the dark blue and light blue are the neoadjuvant treatment arms, and the red and pink are the adjuvant arms. And you can see adjuvant interferon, gamma signature, as well as baseline PD-L1 status and TMB, correlate with event-free survival in both the neoadjuvant and adjuvant arms, except for tumor mutation burden, which actually only correlates in the neoadjuvant arm. So ongoing assessments of these biomarkers and trying to help us with treatment selection, but really what we saw from NADINA was ongoing evidence of true benefit for these patients out to the 2-year mark, and I'm sure we will continue to see updates of these data. Great. Let's move on to the metastatic setting. So lots here and many updates in 2025. First, we saw Dr. Mike Atkins present a 5-year follow-up to the DreamSeq trial. This was the cooperative group trial that evaluated the efficacy and toxicity of sequencing nivolumab plus ipilimumab, followed by dabrafenib plus trametinib, or the converse sequence. So this took patients with BRAF mutated metastatic melanoma, stratified by ECOG performance status 0 or 1 and LDH normal or high. Patients were then randomized to either Ipi plus Nivo, followed by Nivo maintenance, until the time of progression, and then received a dabrafenib plus trametinib, versus dabrafenib plus trametinib first until the time of progression, followed by Ipi plus Nivo, and then Nivo maintenance. The primary endpoint here was 2-year overall survival, which had previously been read out. And now what we saw at ASCO this year was the updated 5-year follow-up. The 5-year data shown here shows about a 30% absolute difference in overall survival in favor of giving nivolumab plus ipilimumab or immunotherapy first. And that's shown here in black, versus starting with targeted therapy, which is shown here in red. You can see the 5-year OS rate in the immunotherapy first arm, 63.3% versus 33.9% in the targeted therapy first arm. On the right, you see progression-free survival. These continue to be widely separated out to 5 years at 39.4% versus 12.8%. And the median progression-free survival has now been reached in the Ipi plus Nivo first arm, which was 26.7 months. That had previously been reported for the DRAB-TRAM first arm of 8.5 months. So clear evidence of ongoing benefit of using immunotherapy first for the majority of our patients. Many of those early relapses on targeted therapy were actually in the central nervous system. And so Dr. Atkins presented CNS metastasis-free survival. All CNS events were in the brain. And you can see here, again, immunotherapy first in black versus targeted therapy in red. And you can see clear evidence of benefit at the 4-year mark for CNS metastasis-free survival, 76% in the immunotherapy first arm versus 62.1% in the targeted therapy first arm. We also saw 5-year data from lifileucel, which was the TIL therapy approved by the FDA in 2024. This is 5-year follow-up data from the C14401 trial. And you can see here ongoing and deepening responses is shown in patients by Dr. Medina at ASCO in 2025. Longest ongoing duration of response was nearly 59 months, and there were several patients for whom responses deepened over time. 16 of those patients had stable disease that improved to a partial response, or a partial response that improved to a complete response by the end of this follow-up. And patients who were responding at year 3 continued to respond through year 5. So this would be really reassuring for our patients who receive this one-time treatment that this continues to be durable. Keeping on the cell therapy line, we saw data from the AGNI-01 trial with OBX-115. This is an engineered TIL cell therapy that eliminates the need to give patients IL-2. So patients still undergo tissue procurement either through surgery or core needle biopsy, cell manufacturing, and then infusion, followed by administration of acetazolamide, which actually acts as a cytokine on signal for these engineered cells. These data were presented by Dr. Jason Chesney at ASCO this year. Responses in anti-PD-1 resistant advanced melanoma were quite impressive in this study. You can see the recommended phase 2 dose shown on the right. That was an N of 6 patients, 11 total patients shown here. But at that RP2D, you can see an objective response rate of 67%, or 4 of 6 patients who responded, with 1 patient having a confirmed complete response, and a disease control rate, including stable disease out to 12 plus weeks, at 100% in that recommended phase 2 dosing. So that dose is now being explored further in an ongoing phase 2 trial, and we are looking forward to seeing more data. Additionally, we've seen data now for Anza-cel, which was previously called IMA203. This is an engineered TCR-T cell targeting PRAME. PRAME is heavily expressed in both cutaneous and ocular melanoma. And they presented data from the phase 1 trial in which patients are screened for HLA-0201. If 0201 positive, they were then tested for PRAME, underwent leukapheresis, cell manufacturing, lymphodepletion, cell infusion, and low-dose IL-2. And you can see data here presented by Martin Vermke at ESMO for cutaneous melanoma. Uveal melanoma we'll touch on in just a minute. But 7 out of 14 patients with confirmed objective responses in this phase 1 trial for Anza-cel. Moving on to ocular melanoma, similar in this same trial of Anza-cel, in ocular melanoma, there were confirmed objective responses in 10 out of 15 patients. This is incredible for ocular melanoma, which has had very few treatment options. You can see the median progression-free survival was 8.5 months, the median overall survival not reached. Really quite impressive for ocular melanoma. So what was practice changing in 2025? Well, with NADINA, with longer follow-up, we see increasing strength of benefit of neoadjuvant Ipi plus Nivo. For DreamSeq, ongoing sustained benefit at 5 years and fewer brain metastasis as the site of relapse. And ongoing evidence of durable survival for patients with lifileucel. In 2026, we have an upcoming PDUFA date for RP1 plus nivolumab in April, a possible readout of the Keynote 942 neoantigen mRNA vaccine plus pembrolizumab study for stage 3 and 4 resected melanoma, and many exciting ongoing and actively accruing trials for refractory melanoma, including OBX-115, the registrational trial for Anza-cel, RP1 plus nivolumab, as well as uveal melanoma phase 2 of the Anza-cel trial, which is accruing in the US and in Germany, as well as the RP2 plus nivolumab registrational trial. So we really encourage you to refer patients early and often for these trials, and looking forward to a really exciting 2026. And with that, I will say thank you to the organizers of the OncoAlert Colloquium, and I hope to see you back next year.